everyone for showing up, but I also want to warn Ruth. I've had a number of people tell me they're going to tune in tonight, so we may get some more in the next 5 or 10 minutes. So be prepared. But I I'm so happy that we're finally able to get this subject on our air. We're able to talk about something that is really important. It concerns the well-being of people. We're the only industrialized nation that does not recognize healthcare as a human right, which is an abomination in my way of thinking. And so um, I'm so happy that Ryan, let me see, Stolnik, is that how you pronounce it?
Yeah,
Okay,
Skolnik, exactly how it looks.
all right, Skolnik is here tonight to talk to us. And so, what we're going to ask at the end when we do our Q&A is to make the questions as short as possible, so that everybody can ask a question. Because if we get 6 or 7 more in here, we're going to have quite a crowd. So, anyway, Ryan, I'm just going to turn it over to you and let you do your thing.
All right, thanks so much for that introduction. Good news is my presentation is less than half an hour, and I do that on purpose because I prefer there to be time for Q&A. So really quickly, my name is Ryan Skolnik. I'm an organizer on the Medicare for All campaign at National Nurses United, and really happy to be here today talking about this. It's a very important issue. So what I want to do today is I want to break down 6 core failings. Obviously, you could point to a lot more than just 6 things wrong with our healthcare system, but I find it's helpful to distill them down into 6 major failings of our current healthcare system, and then talk directly about how Medicare for All addresses each of those failings. And then we'll go from there into Q&A. Every different group that I speak to has different concerns and questions about Medicare for All. So I tend to try and let you all drive the conversation after just introducing what it is and how it works. So with that, let's jump right into the 6 failings of our healthcare system. The first one being is that it is not universal. Under our current system, before the Trump tax cuts and Medicaid cuts take effect fully, we have over 28 million Americans who have no health insurance at all, not including probably more than twice that are underinsured, meaning that they have insurance, but they can't afford to use it. The cuts that are implemented to Medicaid and by HR 1, as well as the expiration of ACA subsidies, mean that in the next decade, we are looking at around 43 plus million Americans who have no health insurance at all, meaning they can't afford to see a doctor, they can't afford to get small issues taken care of, they become chronic, all of the ills that come with not being healthy and not being able to see a doctor. The second failing is that our system is very confusing and very complicated. If you've ever picked your healthcare through an employer, there's chances they've given you a bunch of different plans. If you've ever tried to get it through the Affordable Care Act exchanges, there is a good chance that you've had to try and navigate different platinum, gold, silver, and bronze tiered plans, all that have different amounts of cost sharing and all of that. Medicare itself is becoming more complicated as Medicare Advantage plans expand and add more private healthcare, private insurance into the Medicare system. It's not an easy system to navigate. It's very hard to get the care you need because it's hard to know where you're supposed to go to get that care. The third failing is that our system just doesn't cover essential forms of healthcare. Dental, hearing, and vision care are essential forms of healthcare, but they are not fully covered, or at most in very small ways covered under our current system. People typically have to purchase expensive secondary supplemental healthcare plans to cover these things. Failing four, narrow restrictive networks. That is a situation where you don't necessarily get to choose which doctor you go to or what hospital you can go to when you're sick or hurt. Your insurance company, more often than not, will tell you these are the doctors or hospitals you can go to if you want us to pay for your care. The way that insurance companies decide that it's not done to make care more efficient. The way that process works is insurance companies will go to different groups of doctors and say, if you are willing to accept lower reimbursement rates for us, we will put you in our network and therefore you'll have access to all of our subscribers. The result being that your network, the doctors you are allowed to see, are determined based on who insurance companies can get away with paying the least amount of money to. The fifth failing is probably the most obvious one, which is that our system is just too expensive. We spend more per capita on healthcare than any other industrialized nation in the world, and yet we have worse health outcomes than those nations. We do that because private insurance in this country, for-profit private insurance, is very inefficient. Your average private insurance plan has overhead costs that range from 12 to 20%, whereas traditional Medicare, which is the closest analog to Medicare for All, has administrative costs at 2%. When you factor that in with all the other junk costs in our healthcare system, and you want a sense of how absurdly expensive our system is, one of every $3 that you spend in healthcare in premiums does not go to care. It goes to administration. That is not how it works in any other country, and I want to emphasize this a lot. The way our current system works is not inevitable. There is virtually no other nation on earth that has these specific issues because there's virtually no other nation on earth that uses our form of healthcare. And the sixth and final failing is that our system prioritizes the few over the many. If you are wealthy, you can get care just about anywhere, and it's going to be the highest quality care in the world. Whereas if you are working class, you'll often struggle to get any care at all. This is definitely true for people who are on Medicaid. And that's another major thing that is an issue, which is that our current system separates people in many different ways into tiers. The reason why Medicaid was targeted for cuts in the most recent H.R. 1 bill from Trump was because Medicaid services some of the most vulnerable people in the country. The low income, they're more likely to be sick, they're more likely to live in lower income areas, rural areas. These are people who are least able to politically fight back, and that's why when it's time for budget cuts, they're often the target. Whereas you notice they did not include direct Medicare cuts because Medicare covers a different hard to attack group of people, which are seniors. So our current system separates us and leaves people vulnerable, all while the wealthiest do great. So, to summarize everything that I just said, the 6 major failings of our current healthcare system. It's not universal. It's a confusing and complicated patchwork. It provides incomplete and inadequate benefits. It has narrow, restrictive networks that make it harder for people to get the care they need. It's too expensive, and it prioritizes the few over the many. Again, this is the nature of a fragmented system where you have a ton of different payers because you have different insurance companies that operate different plans in different markets. So there are thousands of markets across the country. When you fragment our system that much, it costs more money for each person in that system to maintain it. An example of that might be if Bob and I are the only 2 people in paying into a healthcare pool. If I need a $2,500 procedure, it takes $1,250 from each of us to cover my care. Keep that in mind for later. So that is the intro to what is wrong with our healthcare system. I could obviously go a lot deeper, but I think we all know. I'm going to now jump into part 2, which is how Medicare for All addresses each of those failings. We tend to talk about how Medicare for All works through the lens of what we call the 6 principles of Medicare for All, which is not only how Medicare for All works, but how we view a just healthcare system to work. The first principle being universal coverage, the second being a single public program, the third being comprehensive benefits, fourth, freedom to choose your care provider, fifth, no cost sharing at the point of service, and sixth, a just transition. I'm going to go over each of these really quickly. So our first failing of our healthcare system is that not everybody is covered. Under Medicare for All, everybody in the country that is a resident of the country is guaranteed healthcare as a human right. Not access to a doctor, but guaranteed healthcare as a human right. The second failing of our healthcare system is that it's confusing and fragmented. Medicare for All implements a single public program called a single payer that pays for all essential care in the country. That makes things a lot simpler regarding billing because you no longer have the issue of a bunch of different insurance plans having to talk to each other and coordinate who's paying for what when and what percentage of it. That's why Medicare, traditional Medicare, has administrative overhead costs of 2%, whereas private plans have several times that because it's much more efficient to have a single public program responsible for financing. The third failure of our healthcare system is that it provides incomplete and inadequate benefits. Under Medicare for All, care is truly comprehensive. You get all the essential guaranteed care under the Affordable Care Act, plus dental, vision, hearing aids, home and community, as well as institutional, long-term services and supports, and more. Even more importantly, under our current system, whether you get care or not is often not decided by your doctor, but your insurance company. Your doctor could tell you you need something. Your insurance company might say no. Under Medicare for All, if a qualified healthcare provider tells you you need something, that is sufficient to get it covered.
Hang on a minute.
The fourth failing of our healthcare system is that you have fragmented networks that are determined by your insurance companies. Under Medicare for All, there's only one network, which is the entire country. You can see any practicing provider in the country under Medicare for All. The fifth failing of our healthcare system is that it's way too expensive, both on a systemic level and for families. Under Medicare for All, there is no cost sharing at the point of service. Under Medicare for All, you go to the doctor, you get the care you need. You don't have to worry about a copay when you go to the doctor. You don't have to worry about balance billing, where they send you a bill after the fact that you didn't even realize you owed. Medicare for All payments to a healthcare provider are considered payment in full. The only thing you would pay for under Medicare for All are things that is the taxes that pay for the system on the back end. Taxes that under every single proposed financing plan would save families thousands compared to what they currently pay in our healthcare system. And then the final principle is a just transition. Under our current system, the few come over the many. Under Medicare for All, everyone is covered, and that takes a few different forms. First, the transition to Medicare for All itself takes only 2 years. The first year expands healthcare under Medicare for All to everyone 18 and under and 55 and over, and allows everyone in between there to buy into Medicare if they want. That's the first year. The second year, everyone is covered. There's a fast implementation period because the longer we wait, the more people are going without care, the more people likely to die without the care they need. But in addition, it's not just a transition to the system, it's a transition for people who might be impacted by it. Our insurance companies, in our view, add nothing positive to our healthcare system, but the people that are just doing their jobs, like as claims administrators or whatever, shouldn't be punished by the transition to Medicare for All. Which is why for the first 5 years of the Medicare for All program, at least 1% of the entire budget, which is several billions of dollars every year, will be set aside specifically for transition programs for people whose jobs are impacted by the switch to Medicare for All. And that could take lots of different forms. That can take the form if they want to learn a new trade, they can get their tuition reimbursed going back to school. If they're looking for a new job, it can take the form of gap wages. They could get priority placement to do similar types of work in the Medicare for All system. It's a flexible fund that tries to make the transition as seamless as possible. So these are the 6 principles of Medicare for All and a basic overview of the benefits that come from implementing a system like Medicare for All. But they're not the only benefits to Medicare for All. Medicare for All curbs hospital profiteering. Hospitals become publicly funded under Medicare for All through a negotiation process, which means that money that they receive has a lot more transparency to it. In other words, it has to be used for actual care. It can't be used for other non-care things like CEO buybacks or anything like that. No using payments for marketing, lobbying, or political contributions. Limits in executive compensation and bonuses. This next one is very important. Medicare for All fully funds rural and safety net hospitals. The negotiation process through which hospitals are funded takes into account where the hospital is, the types of patients it takes care of, what those patients' issues typically are, all those different types of issues for the hospital. There's going to be a specific amount of money that's granted quarterly to that hospital, specifically to account for all of those things. Under our current system, hospitals largely rely on foot traffic. And that's why Medicaid cuts are devastating for hospitals. The biggest hospital chains might have investments, but that doesn't help people in rural and medically underserved areas. So not only does Medicare for All fully fund these hospitals, but it also includes a separate special projects budget to ensure that they can get extra funding. For example, if you have an area where there's a healthcare desert and there aren't enough doctors, an area could receive supplemental money to offer doctors willing to practice their higher wages. Things like that to incentivize more people to practice medicine where they're needed most. That's the opposite under our current system, where people in rural and medically underserved areas tend to be on Medicaid, which pays doctors less than other plans, which means doctors are less likely to practice where they need most. That's the opposite of how it should be. Medicare for All reverses that. All of this, I might add, is at a lower cost than our current system. And this is where people say, that sounds wild. How does that work? And that is how much of an anomaly our current healthcare system is. Under our current system, administrative costs are the highest in the world. Medicare for All, like I talked about earlier, simplifies that, curbs the profit motive, cuts advertising budgets. Bulk drug price negotiation is a major source of savings. Under our current system, it's with a bunch of different plans, fragmented. No plan has the economies of scale other than Medicare, which is forbidden from negotiating for most drugs, to negotiate with drug companies for lower prices. When you have Medicare for All covering everyone, that is a huge payer. You have the economies of scale. What are drug companies going to do? Not sell drugs in the United States. So United States has the ability to bring down drug prices through leveraging its buying power under Medicare for All. Medicare for All refocuses care on primary and preventative medicine rather than a system we have now where people skip care because it's too expensive, develop chronic conditions, and then become much more expensive to cover. So we save money by catching ill issues before they become more expensive. And this is the big one. One single risk pool to more evenly distribute the cost of the system. Remember what I said earlier, where if Bob and I are the only two people in a system, we each have to pay for half of the cost of a procedure. But let's say that you add Doris and Mohammed to that pool next. Now, each person paying into that pool is responsible for a quarter of the cost of that procedure. So the more people you add into one plan, the less it costs per person to maintain that plan. That's the major source of lowering costs for families. One single risk pool where everyone pays into. In the United States, 5% of people with the most severe chronic illnesses, are responsible for 50% of all healthcare spending in the country. So you take those 5% of people and put them in the same pool as the 95% of people who aren't as sick, and that distributes the cost to everyone in a much lower way. So that is why study after study, including conservative libertarian studies by the Mercatus Institute, the Congressional Budget Office, and a meta-study of 22 different single-payer plans, all found that a system like Medicare for All would save money over our current system. Our current system is just that inefficient. So I did want to make the actual education portion as quick as possible because I wanted to be able to answer as many questions as possible. So I'm going to go ahead and end the slideshow at this point and just say unless Bob or Mohammed have anything they want to say beforehand, I'm ready to take any questions you all might have.
Mohammed, you're on mute.
Muted. Yeah.
Right. Well, Ryan, thank you so much for this wonderful presentation. I mean, this is really an eye-opener, and I don't see why there has been so much resistance to a universal healthcare plan for everybody in this country. It's really shocking. So those of you who have questions, um, just unmute yourself, ask your question, and then mute yourself again. Okay, go ahead. Yes, Ruth. Oh,
Roger raised his hand.
okay, Roger.
Yes, I was as I was listening to your presentation, really good presentation. Um, I was sitting there thinking, you keep hearing about this socialized medicine, and socialism. So uh, I see this as a benefit for the society, for society as a whole, because that's one less problem that we have to deal with because our health issues become the major issues in our life and as far as we get older.
Was Howard, did you have your hand up?
Yes, I had two questions. One is an operational one. Is it possible for us to get a copy of those slides?
I can create an unbranded version. We have an org policy against giving out a branded presentation, but if you give me a few days, I can create an unbranded one to send you if that works.
Would really appreciate that for looking at that.
Yeah.
Second thing is, I didn't see you get into the struggles between the insurance companies and the doctor's professional opinion and control. I raise an autistic person, and we frequently get into that's an issue there. The other one is, did you want to talk about how the system might discipline the medical community for things like coordination? I deal with different doctors' offices, and the coordination across the net and in other ways can be very difficult from office to office, or in getting doctors to clear drugs to be that sort of thing. Enough said. Appreciate your patience. I'll get out of your way.
Yeah, of course. So two questions there. The first was on insurance overriding doctors. I touched on it briefly, but it definitely merits a little bit more of an explanation. So under our current system, doctors are not the final word. They can tell you you need something all you want, write you a prescription, send you to get a procedure. But if your insurance company isn't going to pay for it, that doesn't help you at all because unless you're willing to pay out of pocket, you can't get it. Most often, insurance companies are not qualified to make that determination. And they don't make determination based on medical necessity. They say they do, but it's really about the money. And their game that they play is how clear cut is this coverage benefit and what is our wiggle room? And the more expensive the procedure, the harder they work to find wiggle room. That is how they work. Medicare for All, the Medicare for All Act includes explicit language saying that not only is the medical determination made by the qualified medical provider, meaning that the payer under Medicare for All, like the US government can't just say, do what insurance companies do and override a doctor. They can say, if the doctor prescribes a covered benefit and says it's necessary, that's sufficient. Under that, as opposed to our current system. But not only that, Medicare for All includes explicit override language, meaning that if there are practice standards that make it harder for patients to get the care they need, and that is interfering with their ability to get patients covered benefits that they need, because that can happen sometimes. Providers, especially when it comes to things like electronic health records, providers actually have the right to override those things. It's inscribed in law. The idea here being that the job of a payer, namely the Medicare for All program, is not to decide what is care or what isn't. Its job is to say, is this a covered benefit? Does a doctor say it is? If so, here's the money. Regarding care coordination, Medicare for All can address that as well. One of the major issues right now is doctors don't coordinate care with each other. One, because they don't have time, because they're constantly fighting with insurance companies, but also care coordination doesn't slot neatly into the fee-for-service model. There are other ways in which you can reimburse doctors for that specific type of care. For example, you could do a time-based payment for care coordination specifically. There are ways in which Medicare for All can ensure that care coordination is done because it's a very important part of care, and make sure that they're compensated for it to encourage that to happen.
Okay, I think next is
Thank you.
Julie.
Hi. Real quick, well, two real quick questions. First of all, if we were to call our reps and lobby for this, what would you recommend we say? And secondly, what do you think is the worst piece of propaganda that you have to fight against?
Great questions. So when it comes to contacting your representatives and what we recommend we say, obviously that depends on your representative. If your representative is a conservative Republican, chances are it doesn't matter what you're going to say. You're going to say they're not going to support Medicare for all. Conservative Democrats might be more moved by the fiscal arguments of how it saves money and is more sustainable. More progressive Democrats, healthcare is a human right language. It really depends on who your representative is. In general, I tend to tell people to focus on the economics of Medicare for all because most people can agree that everyone should have some form of healthcare. There are some people that don't agree, but most people do. But the details are where it matters. And that actually brings me to your second question. What is the worst piece of propaganda? Which is that Medicare for all is a slogan, or it's not a serious proposal, or it's pie in the sky. The Medicare for All Act is a detailed implementation-ready bill. It doesn't include financing because there's a ton of different options for financing. That would be is intended to be included in the markup process. But Medicare for All Act otherwise is implementation ready. It's a proven model that exists in several nations across the world that have much lower costs and much better health outcomes than we do. So the propaganda that I think is the most frustrating, obviously there's more prevalent ones, like it's too expensive, et cetera. But the most frustrating one is when people, and it's often more conservative Democrats actually who use this language, is that it's not a serious proposal and that we need to be realistic. What's unrealistic in our view is trying to patchwork fix our current system. We've tried that for a long time and it's never worked. In our view, moving to single payer is the more realistic way to move forward. That's just us.
I think next is Aziz.
Thank you. Very nice presentation, very nice program. It's much needed. I in insurance business for 40 some years, 1983, and it pains me when I propose supplement to Medicare, because Medicare doesn't pay, current one doesn't pay all of it. People have to pay 20%, and then there's a cost for Part B, which is outpatient. Average is $206 a month for now, which goes up every year. But people with a high income, they pay $400 to $700 a month. So, having said that, of course, it's painful other way. Medicare supplement is, which is for rich people, they get a Medicare supplement, and people who have 70%, people who have a low income, they get Medicare Advantage plan. So there are disadvantages of this Advantage plan actually. So my question is, probably you have already placed in funding. I'm willing to pay $300 a month. So how will this be funded? What is it a gradual fund down the road will self-pay itself, or there's a somewhere money could be taken where people have to pay just flat fee per month? That's my question for what you are proposing. Thank
That's a
you.
great question. Yeah, of course. That's a great question. So I want to start with the broad principle, which is that it's not paid through monthly premiums or cost sharing. It's a back-end system of progressive taxation, is how Medicare for All will be funded. Now, moving more specifically into what that looks like, I want to tell you something that not everyone in my team likes to say. Not everyone likes using this framing, but I think it's very important, is that right now in this country, we pay the highest healthcare taxes in the world. We just don't call them taxes. We call them premiums, copays, and deductibles. And we pay them to private companies rather than the government who have a profit motive. So with that said, the question is, how do we take our healthcare taxes we pay to private companies and redirect them to the single payer that's being set up? There are a ton of different proposals to do that, all of which have different benefits and drawbacks. For example, one of the commonly proposed ones is a gross receipts tax on businesses to ensure that businesses pay into it. And that's great, a great idea in theory, because businesses won't have to pay for healthcare anymore. So it makes sense that they contribute to the system. But if you don't include enough exemptions on receipts for small businesses, you're going to crush a lot of small businesses that can't afford a gross receipts tax under our current economy. If you want to do something like a sales tax, it would probably have really low administrative overhead because all the infrastructure for sales taxes already exists across the country. But if you don't include enough essentials, that becomes a regressive tax that overwhelmingly hits lower income people. So there are a bunch of different proposals. Bernie Sanders actually put out a whole white paper on Medicare for All. If you just Google Bernie Sanders Medicare for All white paper, you'll find a document titled Options to Finance Medicare for All. And it has a laundry list of different things, along with how much money it will save. So the question isn't really how do we pay for it as much as it is how do we redirect the money that we're already paying for our healthcare system to where it should be going, not shareholder profits, but to our actual healthcare system. And the way that in which it's going to be done depends on what the people who are making policy decide is the most politically and economically feasible ways to do it, which is why we left it for the markup process rather than codifying it in the bill. And also, the healthcare landscape changes a lot. And a financing mechanism that would raise adequate money right now might not in 4 years. So it's important to tailor whatever financing mechanism that we develop towards the moment, not where things are right now, if that makes sense.
Thank you.
All right. Who's next? Bob? Well, Bob and
Yeah.
then David.
Okay. One of the criticisms that you hear from the far right is that if you need an operation, you'll be delayed 6 months. And this is really, really terrible. You could die in that length of time. And when I went to Canada, I talked to someone about that. And that wasn't true. But could you address that question?
Yeah, so that's a very common one. And people get there from a misunderstanding of how the Canadian system works. So when it comes to life-saving care, you're never going to be on a wait list in Canada. You might be on a wait list for care that is needed but not life-saving. And the reason for that is because that is the way the Canadians
Meeting. Okay.
that is the way that the Canadians have designed their system. They have artificially created scarcity on certain procedures to make their system less expensive. And they do that in a few different ways. They limit where certain procedures can be done. They limit how many people can be licensed to do those procedures. And they do that because it saves the system money. It also artificially generates wait times. There are lots of single payer systems, Taiwan being the first that comes to mind, that don't use that model. And essentially what it comes down to is if we're willing to pay more money to not artificially restrict the availability of services, then we won't have that issue. If there is going to be an issue when it comes to wait times, which it's going to be having enough doctors. And Medicare for All creates within the program the Office of Primary Care, which has a bunch of different roles, one of them being ensuring we have enough doctors and proposing programs to do that. So there's nothing inherent to a single payer system that creates wait times. It just depends on how we design the system, like it would any system.
I think I made a mistake. I think Kathy was next and then David. So Kathy, go ahead and unmute and speak your question.
Oh, Kathy, you're muted.
You're muted.
Yeah.
I used to work for an insurance company, so I don't have great opinions of them. But what about the lobbyists? How much of a fight are you going to have with the insurance lobbyists to get this through? Because I know they'll fight tooth and nail.
Oh, it's not, you're absolutely right. And it's not just insurance. If you worked in insurance, you know full well that the insurance companies, the drug companies, and the hospital companies all hate each other. And they're always fighting with each other. This is the one issue where all three of them are united. They don't want Medicare for all. So it is a huge fight. They actually have created a front group. It's called the Partnership for America's Healthcare Future. And its entire purpose is to kill Medicare for all. And they've already spent millions and millions of dollars since it was first formed in 2018 to lobby against Medicare for all. And they work, and the reason they do that is because insurance companies, private insurance anyway, would cease to control our healthcare system anymore. They wouldn't be able to pay for essential care under Medicare for all, which means they'd be relegated to covering only things Medicare for all doesn't. And that's not a profitable business model when Medicare for all is comprehensive. So they're going to do everything they can to kill it. And that's why we do presentations like this and why we encourage people to get involved, because it is going to be a fight and we're never going to have more money than they do. So it's going to require a groundswell of support in order to win it. The same kind of support that it took to overcome the American Medical Association and pass Medicare in the 60s. They did the exact same thing that the insurance, drug, and hospital corporations are doing now. They've been beaten before, and we can beat them again if we build a strong enough movement.
Okay. David, did you have a question?
I've got I think there is going to be an issue when you suddenly start this. There may not be enough doctors initially until you have a ramp up period, and that's my first point. And the second point is the number of bankruptcies is huge. Most bankruptcies involve medical debt, and I think that's an important thing to mention. And then I had a third thing and I forgot it. So
Yeah, of course. So you're absolutely right regarding the risk of a doctor shortage. The reason why Medicare for All has a 2-year phase-in is partially to gradually expand the program. Like I said, you have 18 and under, 55 and over, and then a buy-in, which will help mitigate it to an extent, gives us 2 years to implement programs, but it's going to take longer than that. Whenever you move to a new system, there's going to be some strains. We moved to the Affordable Care Act, and there were strains there as everything got set up. And even though it's not a perfect system by any stretch, it's still miles better than what existed before it. So we're not under the illusion that we're going to pass Medicare for all and every healthcare issue is just going to disappear immediately. But Medicare for all creates the mechanisms through which we can address these long-running crises. And that's the thing. There is a shortage of providers willing to practice under our current system already. So if we do nothing, we still have that issue. Medicare for all isn't going to solve it overnight, but it does create the mechanisms to help address it. And I think that's important. And you're absolutely right about medical debt. That's why Medicare for all does no cost sharing at the point of service, because it doesn't do anything but make it harder for people to get the care they need. People will say, well, if you do cost sharing like copays and deductibles, it makes sure people don't get care they don't need, as if people love going to the doctor. That's not a thing. But in addition to that, all it does is make sure people don't get care when their issues first come up. So then they become chronic and they have to get care, which is much more expensive than if they just got it to begin with. So they don't make our system more affordable and they make it harder to get care. It's a lose-lose.
Bob?
Quick question. So Ryan, you are charged with putting all this together, and they say, let's make Medicare for all. What country would you say is the Cadillac of all the single payer countries that are around the world? Which one is the best?
That's a tough one because the different single payer systems around the world have design features similar and different to ours. Because I want you all to remember, Medicare for all is not a change in delivery. Doctors don't become government employees under Medicare for all. What changes is who they bill. They'll bill the government instead of insurance companies, but they don't become government employees. That's different to obviously the United Kingdom and their NHS system, where doctors become providers, hospitals are run by the government. But if you want to talk about financing aspect, the UK, Taiwan, Australia, and Canada are all examples of the type of financing that single payer is. What I will say is that those systems aren't perfect analogs. For example, Canada doesn't include things that are included in our program, like prescription drugs, which people typically buy secondary plans for there. So our system is going to cost more than the Canadian system will, but it's also going to be a lot more comprehensive. So we're essentially building a system based on what we know about single payer systems across the world and how they work, making it more comprehensive. And yes, it's going to cost a bit more than those systems, but our current system is so wildly unaffordable that that's something we believe we can do. We can do a more comprehensive system that because it's still a much lower cost than people are currently paying for healthcare.
I have a question, Ryan. Can Medicare for all be implemented by states independent of the federal government?
That's a great question. There are several bills in different states across the country to do that. The long story short is it can, but it's very difficult. Reason being that you don't need Congress to enable it, but what you do need is the federal government to allow states to use federal money in ways they're normally not allowed to. For example, here in California, where I am, the federal government is responsible for about 40% of all healthcare spending in the state. So if we aren't able to redirect that money into the Medicare for all type system we're trying to do here, then we'd have to raise the entire cost of the system ourselves, which is way too expensive without that 40%. And there are ways in which you can do that, but you need a cooperative federal government to start that process. So the answer is right now, no. With a president more willing to allow their HHS to work with states, it's possible. It's difficult, but it's possible. So the way we see it is from a policy standpoint, Medicare for all at the federal level is way easier. But it's probably a lot quicker in terms of the political realities to do it in certain progressive states first, which is kind of where the difficulty is.
Anybody else have any questions?
One question, if you got is the effect of all the medical bankruptcies creating a situation where we might get an alliance from the financial community? I mean, I don't see that they're making a lot of money or that it's very successful over driving people into bankruptcy. Or am I being too idealistic?
I think what people are forgetting is the type of social control that comes with our current system's healthcare arrangement, where people are tied to their jobs, where there's a lot of private equity invested in the for-profit healthcare system. That is probably what the finance industry is most worried about, is the shocks that come with ripping a ton of investment out of the economy that way, in their mind. And also, again, the Fortune 500 companies, even though they'd save money under Medicare for all, they value the ability to offer better healthcare plans than anyone else because they can get the best talent. So they benefit from the social control aspect of our current system. So that's another thing we have to contend with.
Thank you.
Bob?
One thing you said early on that caught my attention. You said that the administrative costs right now are about a third, if I'm not mistaken. I thought that when Obamacare went into effect and everything, they were limiting that to 20%. Am I wrong?
They are under 20%, but often just barely. For example, there's been multiple studies. AHIP, which is the insurance company conglomerate, recently cited 18% as the average for for-profit insurance plans. So there's a lot. So that alone isn't where a lot of the administrative junk comes from. That's just probably the largest source of it. But the thing is, you can't. 18-20% is still way higher than any other system on Earth, even if you were to remove everything else. So that's a major source. And it's also not the only problem with our system being fragmented. It's also really hard for people to figure out where they are supposed to go and who they're supposed to talk to get their care covered and approved, which is by design. They don't want to cover it, so it being hard is not a bad thing for them. But yeah, it is under 20%, but often just barely.
Judy, your hand is still up. Okay, I guess it's. Ryan, I got one quick question. Will Medicare for All make these thousands and thousands of workers in the healthcare insurance industry lose their jobs and they won't have any place to go?
Good question. So I mentioned in the slides that there is a 5-year transition fund established by Medicare for All to help people whose jobs are impacted. Not everyone who works in insurance will lose their job because people still need, you still need, obviously not the same type of job, but something similar in the Medicare for All system. And priority hiring could be part of that process for those people and make sure that their jobs aren't impacted. But for other people, yeah, there are going to be some people whose jobs are shifted around because without we're getting rid of the for-profit insurance companies. So that's why we have a large multi-billion-dollar reserve fund that can be tailored towards helping people who are individually impacted by it. Like I said, some person might be 63 years old and say, I'm close to retirement. I just want to retire early. That fund can be used to supplement their retirement income. If they're very young and they've always been interested in learning a new thing, they weren't able to because of how expensive healthcare is, they could have their tuition reimbursed. If they have another job lined up, but they're not going to start for a month and they need to pay their bills, it can take the form of gap wages. So there's all sorts of ways in which that fund can be used, but the system is designed to try and make it as painless as possible for the transition. And the transition is inevitable. We can't say nobody is going to lose their job when we're getting rid of the insurance companies, but we do our best to mitigate the issue. So I'm going to put in the chat. What's that?
I was going to say one thing. You said that you're going to send something to Muhammad, a video and what have you. I would love for you to do something like a 30-minute video so I can send this out to other people. This is this I really want to thank you.
Yeah.
It's my pleasure. So this is being recorded, and I am going to create over the next week or so an unbranded slide deck I can send you. The other thing I'm going to do is put 2 links in the chat for ways for y'all to get involved. The first one is for individuals. If you want to sign up to get updates about the Medicare for All campaign as an individual and maybe plug into actions as they happen near you, that's the first link. If as an organization you want to endorse Medicare for All and get organization specific updates from the campaign, then that's the second link. So I'm thankful y'all had me here. I'm glad that it was helpful. And I'm also going to put my email in the chat. So if anyone has any follow-up questions, you can just send me an email.
Hi.
I have a question.
Yeah.
Go ahead, Julie.
Oh, okay. Thank you. I think this is something, your presentation is something that my church would be very interested in. Do you think it would be possible, if I can get my pastor's approval, of course, I would have to have her permission, but do you think you'd be willing to give this Zoom presentation like what you did tonight? Do you think you could do that for a church? Do you think that'd be appropriate? Would that be okay with you?
Oh, absolutely. Again, if you email me there, we'll get it organized.
Okay, cool. Thank you.
Anybody else have any questions or comments?
Yeah, I have one quick question. We know that the hospitals and insurance companies are going to be against this. I'm curious about doctors, whether how much pushback from practicing doctors you anticipate.
That's a great question. The long story short is there's a huge generational split right now. Elder doctors that are specialists tend to overwhelmingly be opposed to Medicare for All because Medicare for All reorients financing to prioritize primary care, which means that the highest paid doctors in the country are likely to be taking mild pay cuts. So obviously they don't like it. People who are younger doctors, typically in primary care, who have tons of student loan debt, they tend to love it. because Medicare for All would make it to where they don't have to go into a specialty field and get even more debt just to make enough money to pay off their debt. And they also don't love the idea of spending their entire life fighting with insurance companies. So the American Medical Association, while they're still in opposition, they did leave the Partnership for America's Healthcare Future, which they were initially a part of. And we've seen statewide doctor organizations start to thaw. So they're not there yet, and there's a lot of work to be done. But doctors are a lot more amenable now than they were when they were fighting Medicare in the 60s. So we just got to continue that organizing work.
Okay.
Well,
How could you how could you shape the plan so that it would give doctors more freedom from the insurance companies?
Well, they wouldn't be dealing with insurance companies under Medicare for All unless they're providing non-essential care that isn't covered under Medicare for All, because under Medicare for All, private insurance is not allowed to cover the same benefits Medicare for All does. So they would only be dealing with the Medicare for All system. And since there is a defined set of benefits, if they know that if they prescribe something that is covered, that it's going to be covered because their judgment is what matters. So it actually saves a ton of time for doctors.
Thank you.
So people could still get elective, quote unquote, elective surgery, but it wouldn't be covered, basically.
Correct. They could get third-party insurance for non-covered services for Medicare for All. So if you want a non-medically necessary facelift, you can go out, you can get that and get it covered by a private company as long as it wouldn't be covered by the Medicare for All system.
Mhm.
Okay.
Okay, if there's no other questions, I want to thank Ryan. This was a wonderful presentation. Lots of good information, and yeah, once you have the revised charts, email them to me, and I'll share it with all our members.
Of course. Thank you all so much for having me. It was
Yeah,
great
thank
talking
you.
to you all.
Thank you very much.
Thank you.
You all have a great rest of your meeting, and feel free to email me if anything else comes up.
Okay,
Thank you. Have a blessed one.
Thank you.
All right, so let's see, the September meeting, it's that Monday falls on Labor Day. So we have not, I think, Bob, did we decide that we're going to stay with September 7th?
You and I talked about it, but I wasn't too sure what we came up with. So um, we might want to do it. Would everybody be available? Are you going to visit your grandkids? Are you going to take a trip on Labor Day? If not, we can still have it on Labor Day.
Not going anywhere.
Okay.
We'll probably be at home too.